Good evening, uh, Dr. Anand Krishnan sir, Dr. Manju, Dr. Grace. We welcome you on behalf of the DPH icon. So it is definitely a privilege to have some, and Dr. Prashant Mathur has joined. So let him join. In the meantime, I will just brief on what is this session about. Definitely a privilege to have some experts on any topic. Now, we have experts who are working on improving mortality statistics across the world and across the country, and particularly in Tamil Nadu. So, what we have been experiencing is the mortality data in Tamil Nadu is relatively stronger when compared to other states in India. But, however, we have some challenges in the form of medical certificate of cause of death. So we wanted to address this issue and we took up one district CRS approach with the support of WHO. Mortality statistics with a digital innovation is an enhanced, and it was titled here as Beyond Numbers. Over the past presentations, we have many insights ranging from strengthening civil registration using verbal autopsy and leveraging national collaborations. They are not numbers, they have some information behind each number. Reliable mortality data allows us to allocate resources, formulation of policy, changes or amendment in the policies, and improvising the health system. Definitely, in the past 100 years of public health, and also in the Tamil Nadu health system, we have been changing or innovating new programs. Allocations have improved, but not to the expected amount, but the prioritization have been done. In order to commit for building a strong data system, we have collaborated with institutions like NCDIR, WHO, and also we have associated with many related departments. We have improvised a lot, as I said, but the real number, that is the quantum of death records, which a definite medical cause is only 45%. The registration is 100%, whereas the medical records we have is 45% on an average. So, this is definitely a significant gap in mortality surveillance. To bridge this, we piloted a CRS approach in Krishnagiri and Karur districts, and we had a first-hand experience on how to improve or what was the output. That is what we are going to discuss in this plenary. And also, here we have Dr. Anand Krishnan, who has large and vast experience across the states in India regarding the mortality statistics. And we have Dr. Grace, who is working as a lead in WHO country office for health financing, and also we will have a perspective on how this health financing will support the digital data systems or mortality statistics in India or in Tamil Nadu. So I will request Dr. Manju. I think you can present what happened in Karur and Krishnagiri and what was the output, please. Thank you.
So, good morning everyone present here. I'm Dr. Manju from WHO. I work as a district health coordinator. As already our director sir mentioned, we have 100% of death registration that is happening in Tamil Nadu. But there is only 40% of MCCD that is available. And when we talk in terms of MCCD, there are two types. One is a Form 4, another one is a Form 4A. Form 4 is something that has been collected in the institutions, whereas the deaths that happen outside the institution, there is this form 4A where the cause of death is being documented. So in our state, the documentation of form 4 is 100% because all the medical officers, any death that happens in the institution, the medical officer is supposed to provide a cause of death certificate for the death. So the main challenge we had is that to cover or to ascertain the causes of deaths for those happening at the road or at the home. So these were the major aspects that we were looking into. So when we look into the major aim of this district CRS approach that was piloted in district of Krishnagiri and Karur, the aim was to estimate the proper causes of death for all the deaths that is happening in the district. So, and when we look into the objective, we had three major objectives. One is to integrate the verbal autopsy system into the existing CRS system. The second is to the second objective is to collect the reliable cause of death information system, and the third objective is to improve the analysis and the data collection process in the district level. So with this, if a model is being formed, then this would help us to this would help us to scale up the project at the state level. So this is the picture of the existing CRS system, where the black and white are the system that was already existing with the state government, and the ones highlighted in green is the intervention done. So when we look at this, all the hospital deaths, we do have MCCD, we do have the cause of death certificate which is being documented in the CRS portal, whereas for the home deaths, let it be a MLC or an unnatural death and MLC, or let it be a natural home death, the availability of MCCD was a challenge. So for those deaths which did not have MCCD, we happened to do a verbal autopsy. So who does a verbal autopsy is that the health inspectors and the sanitary inspectors of the district were trained to be a verbal autopsy interviewer, and these people went to the field, collected data So these people collected the data. So from the using the verbal autopsy WHO questionnaire. So from this data, the medical officers of the respective PHCs determined the causes of death using the PCVA web portal that was designed to ascertain the causes of death. So these information were again integrated into the CRS portal that is already existing with the state government. So our major role here was to ascertain the causes of death for those who did not have an MCCD, and in addition to that have an entire analysis, a comprehensive analysis of all the causes. So with this, in 2023, our achievement was at the first level, we did strengthen the existing human resources. The capacity building of the existing human resources was strengthened. So the one positive thing with this is, for a sustained process, you always need to integrate into the existing system rather than bringing in new resources. So that was a major intention, and we did achieve. So from the training part, as a first, in respect to verbal autopsy, we did have around 80 master trainers on verbal autopsy. So with the help of these 80 master trainers, we did train around 155 health inspectors and SIs, interviewers in Krishnagiri, and around 87 interviewers in Karur. So in addition to that, we also did have a PCVA training, which is Physician Certified Verbal Autopsy, where the medical officers were trained on how to give the causes of death using the data collected by the health inspectors. So we happened to successfully have 51 master trainers in both the districts, and with the help of these people, we did train around 106 and 84 medical officers in each district. So in addition to that, the methods that we used to train these people were, we had lectures and we did have role plays, we had hands-on training for them, and the output from this is that we now have at least one interviewer per PHC available in the entire district of Krishnagiri and Karur. And we also have at least one medical officer available in every PHC of Krishnagiri and Karur to ascertain the cause of death. This is on a minimal level. Depending on the caseload, we did have more than one interviewer or medical officers also. So when you look at this, of the total death, 42% of the deaths only had cause of death information in Karur, whereas 27 had cause of death information in Krishnagiri. So with this verbal autopsy intervention, we did achieve a 98% cause of death for the year of 2023 in both the district. So when we talk about cause of death over here, it is not just cause of death that has been ascertained for the sample. The entire district population was covered with the process. So coming into the results, it's a very short time that has been provided. So we are not going to, I'm not going to get into the depth of the results. I will just give a picture of what is all present in the mortality report that has been released. The report is available in the DPH website, that can be accessed by anyone. So the blue line indicates the sex ratio, whereas the orange line indicates the male is to female death ratio. So here we can observe that even though the sex ratio is at around 1, you could see that there is a strong peak between 15 to 60 years where there are more male deaths compared to female. So for a long time we have been more focused towards improving women's health, more attention towards women has been more prevalent. I think we also need to give more attention towards men's health also. So coming to this slide, you could see that again the number of male deaths are more when compared to the female deaths. So that explains the reduced life expectancy of male deaths compared to your female. So this is something we actually had which actually had a very big impact on the analysis and the results that we had. So initially, let it be Krishnagiri or Karur, they had we had only around 40 to 50% of the causes of death were ill-defined. In the sense, we were not able to find any specific cause for the death that were associated. So ill-defined causes were aging, cough, fever, all these things were mentioned as causes of death. So with this intervention of verbal autopsy and with the recurrent process of recoding and analysis of the data, we did bring this 40 to 50% of ill-defined cases to less than 10%, around 8 and 15% in both the district. So the blue line and the orange line represents a different, blue line is the Krishnagiri district and orange is the Karur. So in our report, we did have the outcome, we did have all these outcome indicators. So the we are having causes, leading causes of death by age, leading causes of death by sex, cause specific, chapter specific causes, in the sense what are all the leading causes among NCDs, what are all the leading causes among infectious diseases, what are the leading causes among injuries, all these categorization has been done. We also did have a non-communicable disease indicator. We did a comparison between the WHO indicator, and we also estimated the years of life lost. So this is an example of your age specific and sex specific causes of death that is being, an example has been provided for the district of Karur. So this is the age standardized death rate. So when you look into this age standardized death rate, we can very significantly see that the road traffic accident among male population, specifically in the district of Krishnagiri, is way too much higher than the deaths that is happening in Karur. When compared to male and female, the RTA deaths are more in male, but rather the male population in Krishnagiri has a very significant higher number of deaths. So all these things indicates that we need more targeted intervention towards these specific components. So the major importance of this report is that we did always have all these indicators and all these values at the state level. A consolidated report of each and every indicator, the death information at the district level for the entire district covering a year was being generated. So district being considered as an unit level, these information will be very useful for the DHOs and the block medical officers to plan targeted interventions in their specific areas. So these are the complications that were associated with diabetes that we observed with our analysis. So we could see that there are so many preventable complications that are existing in the field. So these complications, these were the immediate causes of death. So when I say complications, though diabetes was the underlying cause of death, these complications were the immediate causes of death. So if we had prevented these kind of complications, maybe the person would have lived even more longer. So these are how we are supposed to utilize the report and the data that has been available to generate a targeted intervention and policy making. So this is the comparison of the NCD indicator with the WHO. So you can see that in 30 to 69-year-old, the major risk or the major cause is your NCD that is occurring. But when we looked into the report even more deeper, we also found out that there are major causes of NCDs where this cancer, diabetes, cardiovascular disease and COPD, and these were more common in Krishnagiri rather than in Karur. So these indicators will also help us in as a way to progress towards our SDG. So the years of life lost. We could see that the major causes of deaths in younger age group were more towards suicide, birth asphyxia, and in the middle age group it was more towards cirrhosis, RTAs, and all these things are something that could be easily preventable and it would increase the life expectancy of people. So finally, this is one major initiative, first of its kind that was initiated to cover the entire district. So these reports in detail were discussed with the DHOs of the respective districts, and there are follow-up actions in terms of gap analysis and intervention, targeted intervention that has been in discussion. And this report as such will help the state to formulate policy decisions and targeted interventions. And this is something that is an evidence-based report where where the medical officers can access the causes of death, the percentage of death mortality loads up to their PHC level. It is not just specific to the district, but up to the PHC levels they have an access to the mortality statistics of their respective villages, for which they can have a targeted intervention. Thank you.
Thank you, Dr. Manju. Probably you have not added any emotions to your results because lot of work have been done. The one point to note is this started in the year 2022 and nearly 1 year was spent on planning, not on execution immediately. So during the phase of planning, we did a pre-pilot in Krishnagiri and Karur. In the Krishnagiri alone, we did a pre-pilot. During the pre-pilot itself, we learnt many lessons. For example, one practical lesson is, we used to do similar to maternal mortality, we were using infant mortality verbal autopsy during the monthly collectors conference meeting. So many of the deaths which were discussed in the IMR reviews, in the collectors review, were found to be unregistered in the system. So again, this similarly many surprises we were able to capture, and we incorporated such information to the pre-pilot initiative. And Another point to note from Manju's presentation is, this was not a sample. The verbal autopsy pilot in Karur and Krishnagiri is not a sample. It is for whole universe. So taking all the deaths which did not occur in institutions, because 60 to 70% of the deaths have been found to have occurred in home rather than institutions. Because one practical thing in Tamil Nadu, probably in other states also, what we do is, when a patient is dead, the hospital will record it as against medical advice or absconded for want of avoiding these postmortem issues. So what they used to do is, or probably in the last minute while the patient is gasping, we will send the patient to home. இதுக்கு மேலே ஒன்றும் பண்ண முடியாது, you can take the patient to home. So similar cases where the deaths occurred in home are found to have recorded as home death, we did not find any data for cause of death, because they used to get a fake certificate or a certificate partially truthful certificate. So these were, so we decided, initially we thought of taking a sample, but finally we decided to have all the universe as a sample, and this we have presented in an international forum called Verbal Autopsy Reference Group. It's a social group throughout the world they are keeping, and we have presented this, and no country to my knowledge has done this PCVA and verbal autopsy in the universe, that is without for the whole population. And taking this as a success, we applied for a grant in ICMR, and recently we have got a grant for nearly 6 crores for the Directorate of Public Health to expand this project in few more districts, probably 8 to 10 districts. Abhishek, 8 to 10 districts, isn't it? So now this is a news for you, and we are very thankful to all the stakeholder departments, right from WHO to MMC to NIE, for having this pilot as a successful one. So now we are skipping to another topic where the NCDIR contribution for Tamil Nadu for improving the mortality statistics will be presented by Prashant Mathur sir, who is present online, and Dr. Abhishek will be introducing him for the participants. Please. Sir, welcome you, sir.
Thank you very much. Good evening. You can hear me?
Yes, sir.
Can you hear me?
Yeah. Please.
Okay, thank you.
A hearty welcome, Dr. Prashant Mathur, sir, Director, National Center for Disease Informatics and Research, Bengaluru. Professor Mathur is the Director of Informatics, ICMR, NCDIR, Bengaluru. He is a member of several state and central committees on policies on screening and prevention of cancer, HPV vaccines. He is also a member of the Scientific Council of WHO, Fellowship Selection Committee of International Agency for Research on Cancer, IARC. Welcome, sir.
Over to
good evening,
Mathur, sir. Thank you.
Yes, good evening, everyone, and thank you to the organizers of the DPHICon and to the Director of Public Health. This is a short intervention that I am making in our journey and our collaboration with the Tamil Nadu government in improving the medical certification of cause of death. As was stated that since Tamil Nadu achieved 100% death registration in 2013, but the MCCD coverage was around 43 to 45% only by 2017. So this gap was prioritized by the state of Tamil Nadu, and a information communication technology solution was being explored. During the same time, at our institute, we had recognized this gap because we run the National Cancer Registry Program for India, and we realized that cancer as a cause of death was not being recorded to the extent that it should be. We had already started work on improving MCCD way back in 2015, and we developed the application known as electronic mortality, or EMOR as I would be referring to, which would help in recording and reporting ICD coded cause of death for use by hospitals in India. The Tamil Nadu government had shown a lot of interest in this software, and we collaborated with them. In 2016 to 2018, we worked around how to plan it, implement it, and also worked around software solution. And in 2020, we pilot tested this in 6 hospitals and 3 registration units in Tamil Nadu. And by the end of 2021, this was implemented in all local registration units and hospitals of the state of Tamil Nadu. The features that our software EMOR brought to the table were many. Amongst them, the few ones are use of SNOMED CT terms, which could help us in arriving at cause of death, incorporating ICD-10 list as per the national list of mortality codes, which was mapped to the SNOMED CT terms, and application programming interface, or API, to record ICD-03 terminologies and topographies for malignancies. The EMOR software also brought in a lot of prompt messages to the user by bringing out that this is not a cause of death but a mode of dying, like respiratory arrest, and that to encourage the underlying cause of death. A prompt was also asked to verify whether this was actually an underlying cause of death, and encourage the person filling up the death certificate online to fill in part ABC, lines ABC in part 1, and also record the ICD-10 code. There were quality checks which were built in within the software, and summary tables could be generated. Within a short span of 2 years, we were able to ensure that 100% coverage of MCCD happened across all institutional deaths in Tamil Nadu, and that the average time taken for completion of death registration was 19 days, and which had 10 days for institutional deaths, 29 days for domiciliary deaths, and other deaths, place deaths, were 44 days, and so that we could submit within the legal time limit of 21 days. We also took care of completeness of information by reducing the missing data, data quality, range checks, etc., and provided a template for reporting MCCD. I am reminded that 4 years ago, 5 years ago, when in the Ministry of Health meeting in Delhi, when I proposed this, I was come back to the committee so that this can be that experience to scale it up. Through the MCCD is to improve the non-institutional death also into the CRS system, and the integration of the WHO DORIS tool as an important step for standardization of cause of death recording and reporting. I am sure that with all these efforts being made by the state government under the leadership of the Department of Public Health Systems in the country should be shaped up so that they are user friendly, and when combined it will give us a sense of direction to measure our progress towards the sustainable development goal targets and be able to identify the gaps where we are not able to perform. So I would like to again end by congratulating the state government for being so proactive and all the team members, and a special thank to my colleagues at NCDIR who have been working tirelessly with the state government to make this happen, and we would really like to see much greater heights being achieved. Thank you very much.
Thank you, sir. Thanks for contribution to Tamil Nadu and sharing your experiences now. Now the audience can understand that this is the first experience, and what he mentioned was, and again, this is mortality statistics is for the population, not for the institution. So when you get as data for population, you can formulate policies, and this data will help in definitely a population based. Sir, thanks for your time, and I hope this deliberation will be much useful.
Shortly with DGICMR.
Yes, sir. Yes,
Thank
sir.
you.
Thank you. Thank you very much. So now for the audience, I, on behalf of DPH Icon and for all the participants and experts, I welcome our respected Health Secretary who has graced this occasion, and also our Mission Director NHM for this meeting. It's a surprise, and thank you, sir, for both of you, sir. So we'll continue. So the next one is what is the importance of mortality statistics? So what Dr. Mathur mentioned is the population based data. Now we have to see what is the implication or what importance the population data is given, and also now we have listened to the experience of Tamil Nadu with respect to Krishnagiri and Karur. Now across the states we need to know what is happening. So we have All India Institute of Medical Sciences. We request doctor to give her insights, sir. Thank you.
A few words on Dr. Anand Krishnan, sir. Professor AIIMS. He is the faculty in charge of Clinical Epidemiology Unit and member, Dean's Research Committee at AIIMS. He is a member, School Board of School of Health Services, Indira Gandhi National Open University. He was the chair of Scientific Advisory Committee, ICMR NIRE team.
And we saw some very good examples. HIV. If you want to monitor whether we are achieving SDGs, we need to have data and see what is happening. So without any doubt, mortality data is an extremely critical piece needed for public health planners. And what do we do in any mortality system? First is you have to count all deaths. And as recently as Dr. Somasundaram said, our systems currently don't even count all deaths, right? Even counting all deaths is a challenge. Next step is if you count them, then you ascertain their cause of death. And then you put them in a database which is amenable for analysis, analyze and then use it for action. So any good mortality system should be doing not count all of deaths, though we are improving. Therefore we have sample registration system which counts and then does verbatimopsies in all of them, and I will come to that again later. But use of data for mortality data for planning is still almost non-existent in most parts of India. Nobody looks at data, mortality data, because it comes too late. If you have a data which is 3 or 5 years behind, what is the use of that data for planning? So not only do we need to do it well, we need to do it timely. That is the challenge to all of us. So if you look at India, occurring for registration and even for cause of death, but only about 25% of deaths in India occur in hospital. 75% don't occur in hospital. We saw those almost similar statistics, 40% and 27% in Krishnagiri and Karur. So our challenge is twofold. One is how do you capture deaths which occur outside. SRS captures only 0.6% of all deaths, so it is not a good way to, it's a sample, it is not a universal method as you are saying. And even if you capture, we don't have one database, everything goes to separate databases. MCCD goes somewhere else, CRVS data set goes somewhere else, they don't talk to each other. We are trying to find, I will come to that project, in one district, does anybody have a list of deaths? So all these challenges are still there, which if we are saying that we are going to be a developed country, this is something that we should not do. So what we should be doing is that every death should be counted, every cause of death ascertained. For those which occur in hospitals, we should do MCCD. And I could not hear Dr. Mathur very well, but we all think that medical certification of cause of death is good. It is doctors who are filling cause of death. It is very good information. I can assure you MCCD data is not at all good. Its quality, if you do, almost 25 to 30% is cardiac arrest, completely what we call as garbage codes. Almost 30% of deaths certificates are given garbage codes. They are completely useless. So we need to improve MCCD. We need to cover people who die outside the hospital through verbal autopsies, of filling people who die outside through a VA based system. And we will have to employ digital VA solutions. So this is an excellent example of solving a problem which is very important. We have been doing on this in others. We work with SRS system, which was previously called as the million death system. We code about 50,000 deaths a year through our partners in all states. In Tamil Nadu, our partner is SRM Medical College. And the SRS cause of death data is released because we prepare the report. And we have been doing it for last 10 years, more or less. But we work with Prashant Mathur's team to improve. We assess 6 states MCCD, medical certification of cause of death. Lot of challenges. One of them was Rajasthan, and Rajasthan has now asked AIIMS Delhi to start training its. We are developing digital solutions, and along with other partners, we are working with medical colleges and health and demographic surveillance networks to develop a district level model surveillance. We are doing it in Faridabad and South Delhi. Largely doing same things that you are doing. So we strongly urge every medical college to support this activity and maybe adopt a district and help them. And Tamil Nadu has many district based medical colleges. So I think it's a model that, so it's a model that Tamil Nadu can lead with, where medical colleges work with districts in training, in data analysis, in all sorts of things which I have listed here. So we are developing a digital platform which is completely free. It will give training for verbal autopsies. It will provide training for doctors to do coding. It will provide a platform on which coding can be done. So physician coding will occur. It will give you a platform by which physicians can code the forms. So all of this will provide free of cost to anybody who wants to do it. This is currently being developed. In a couple of months it should be ready. And this uses WHO VA tool, but we are open to using other tools as well. So like what you did in Karur and Krishnagiri, we have adopted 6 districts in India, in 6 states, and trying to do exactly the same. How do we get a universal, what is the model which will enable India to get a universal cause of death? We are looking at 3 models. First model is exactly what you did, is asking them through AIIMS. The second model is a nurse model. Hire 2 models whose only job is to do VA. They are not actual part of the health system, but they will go to each house and do the VA of the identified deaths. Third is a call center model. We are trying to see whether it works. Same, but VA is done through telephonic, through a distance model. So we are trying 3 models to see which works better in achieving universal coverage of cause of death. We are planning a meeting with Dr. Chalapati in Delhi next year on a national symposium on strengthening mortality system, and I would definitely invite Dr. Somsundaram and your team who is working in it to present and share your experience with the others, so that other states in India can also move ahead with it. Thank you.
Thank you, sir. Thank you, sir. It's very heartening to note that this is being taken up in other districts also. Probably if we have a countrywide mortality, now lot of in-migration, so definitely there will be mutual learnings when we interact. So now we invite Dr. Introduce Dr. Chalapati Rao before we hear from Dr. Grace.
Dr. Chalapati research academic collection and validation as well as secondary data analysis for countries in the Indo-Pacific region. India includes verbal autopsy validation in Delhi and subnational mortality estimation. His work...
Listen to Dr. Chalapati Rao. We will like to hear from you, madam. Sir, good evening, sir. I'll request you to wait till the Grace finishes her
I'll wait
turn.
for Dr. Grace's presentation to be
Yes, sir.
completed.
Nice to have you join with us. Thank you.
Good evening, everyone. Dr. Rao, I understand the time in Australia must be very late. I will make it very quick. Good evening. My charge today is to contextualize the data that Manju and Dr. Anand have presented in terms of what does it mean for financing? What does it mean for funding of health systems? I hope I am audible. Am I audible? Okay. All right. So I have very few slides. So I'm going to touch a little bit. Next slide. Oh, I'm the one. Okay. I'm going to touch a little bit on the mortality data and SDG monitoring, because SDG monitoring is, the SDGs are really the determinants for how the money is being sliced, not only at the global level, but at the country level. Secondary, the use of mortality data in high-income countries, and what we see is autopsy in LMICs and how that has affected resource allocation, mortality data and quality monitoring, as well as mortality data targets that are reliant very heavily on good quality data. By good quality data, I mean that it is complete, it is intelligible, as Dr. Adnan had spoken about, and the third thing, that it is disaggregated. So as you could see from Manju's presentation, we are able to get even age standardized data. We are able to get disease-specific mortality data. That is very useful for countries as they are doing their SDG monitoring, but also resource allocation. When we see high-income countries, countries like Australia, Estonia, Sweden, United Kingdom, these countries have matured in terms of their civil registration on vital statistics systems. In terms of governance, they have very clear stakeholders that have been identified to run the CRVS data, and have... And this has enabled them, for instance, in Estonia, this is embedded in the health insurance scheme, and it has helped them to adjust their payment models to be sensitive to the disease patterns in terms of mortality. It also is fully digitalized, although in countries like Australia, being a federal country, these ones vary by the states, and in the UK, theirs is still a bit fragmented. In terms of planning, equity, and data access, these states have used them. So in Australia, it is used for informing the primary health network planning and financing. In Estonia, like I said, it is used for funding allocations. The mortality data is used to inform funding allocations for the National Health Plan and the Estonian Health Insurance Fund. In Sweden, for regional budgeting and performance monitoring, as well as in the United Kingdom. And we shall see a little bit more of that later on. Countries that have implemented automated verbal autopsy, by that I mean have taken it to the digital level. No country has fully automated their verbal autopsy. In Sierra, we have a bit of Bangladesh. All these have been financed by the Data for Health Collaborative financed by Bloomberg Initiative. And so you can see that for low middle income countries, the biggest challenge for achieving full automation of verbal autopsy is financing, and has been heavily driven by external financing, which is a good thing that we are seeing now in India. The government is beginning to take this on. For example, with Tamil Nadu, ICMR is going to be the one that is financing this. That bodes very well for sustainability and ensuring scalability. But where it has been used, so for instance in Bangladesh, Brazil, China, these have been more at the subnational level. None of them has done it countrywide, and for some it has only been some pilots within the districts. But without fail, where it has been used where verbal autopsy has been automated. That data has informed resource allocation, decisions and budgeting. In countries like Australia, Canada, Netherlands, New Zealand and United Kingdom, verbal autopsy data, CRVS data, mortality data coming from their mature CRVS systems has been used for informing quality of care monitoring. The UK has a very mature quality of outcomes framework that has been used to monitor performance, and part of that is mortality data, 30-day mortality data that they use to score providers and the regional health boards in terms of performance, and later on this also feeds into their reimbursement model. Now, in health financing, and this is something that India is beginning to look at directly through PMJ, we have what we call strategic purchasing. Strategic purchasing is where you are using information to guide how you pay your providers, you design the payment model, how much you will pay them, and for what purposes. And so that is where now performance incentives come in, where the purchaser is using bonuses, for instance, to guide the behavior of providers in a particular way. Now, in some countries, like in the United States of America, there are centers for medical aid, Medicaid services, which looks at the main health insurance scheme for the poor, the vulnerable, and the elderly, has been using mortality data for their hospital value-based programs. These programs reimburse providers not for the number of patients that they see, but for the outcomes of care. And so, for instance, in some of these programs, particularly for myocardial infarction, stroke, diabetes, and the like, they provide different, that is charging you for more than you need. And that payment method, we have realized, can drive up health expenditure markedly because it is dependent on the physician to charge as he wishes. With the diagnosis related groups, it's a payment modality that enables you to reimburse for the amount of resources consumed, but also according to the severity of the disease. So for countries that have implemented mature systems that are using those payments, they use mortality data, especially that which is age adjusted, to guide the design of those payment modalities so that patients and providers, a doctor that is seeing a patient, for instance, kidney disease and the like with complications. With that, sir.
This is a newer insight when we compare with the different countries, how different countries use mortality statistics for varied purposes. So, thank you, Dr. Grace, and now we can listen to Dr. Chalapati Rao. So, he was very instrumental in conducting the guide during the whole process, and now we can listen to Dr. Chalapati Rao. Sir, over to you, sir. Are you able to hear us?
Yes, I am Dr. Somasundaram, and I hope I am audible too.
Thank you, sir. Please, sir. Over to you, sir.
Yes, thank you. So at the outset, I would like to thank Dr. Somasundaram and the Directorate of Public Health for inviting me to participate in today's session. Since when we had started these sessions, when we were deliberating as to how more daunting to an extent, but nevertheless, we actually, it's a matter of great satisfaction at this point in time, or in fact, even earlier this year, by April 2025. Am I not audible?
Audible, sir, but little unclear. So, inge the problem.
Okay. I'll try and speak a little bit slower and a little bit less.
Yes, sir. Yes, sir.
If that could help. So, as I was saying, it was a pleasure for me to be invited to participate in this program since 2022 August, and we did think it would be a challenge to tackle the strengthening of mortality district for a whole statistics for a whole district, but still we took up that challenge, and it gives us great satisfaction to now have reached this stage where we have the complete cause of death statistics for these two districts for the year 2023 as presented by Dr. Manju. I would like to highlight three key points as to the drivers at the level of the state government with the support of the Madras Medical College, developing the tools and materials of health intelligence with Dr. Sumati and Dr. Abhishek had a very important role to play. At the next level, I think the success of this project is largely due to the intensive efforts in capacity building that were provided to all the functionaries across all the PHCs, and with the role of the local district medical colleges as well in providing the necessary refresher training and the on-the-job, on-site supervision, which was instrumental in ensuring the data quality. Which also brings me to the third aspect in regard to the meticulous monitoring and supervision activities and follow-up that was implemented at the local level, and for which the role of the district health offices and the district health officers and various block level medical officers was also very much valued. It is the interest in the subject and the academic spirit in undertaking this work which was largely a factor in ensuring that the quality of the data was collected to the best possible level. Now, I would urge everyone present in this room to take an intensive look at the statistical report that has been published. It has large, I think about 35 or 40 tables of data in it, as well as 15 or 20 illustrative sites into the epidemiological underscore the need to guide local area. One aspect that still needs to be addressed, and I would request Dr. Seat for analytical capacity at both the state level as well as at the district level, which is something that will help speed up the production of the statistical reports as well as improve the utility of the data. I will stop here. I would just again like to once again say thank you very much to the Director of Public Health and the state government and everyone for this opportunity, and I wish the Tamil Nadu government and all the districts the very best in continuing on this journey to collect and use mortality statistics for public health development. Thank you.
Sir, thanks for your contribution during our pilot project, and now we could hear a little from you regarding the design plan and also the training of district health officers. That was what he was mentioning, and this has given us different insights, and surprisingly, to be precise or to cite an example, that we found drowning to be the cause of death, but the cause of death as drowning was not found out in the records. So now people are interested to introduce a program for prevention of drowning. So this is what is the outcome of this verbal autopsy exercise, and Dr. Chalapati Rao sir was very much guiding through and into the whole 2 years or 2.5 years program, and we hope to get continued support from you, sir. Thank you. Thanks for your insight, sir. Thank you, sir. So I request the audience, if you have any queries or if there are no queries, we can give a big round of applause to the speakers, because this is going to take a break in Krishnagiri and Karur. Thanks, madam. And Dr. Manju, who is consultant in consultant WHO for Karur and Krishnagiri, and she is very eager to introduce and expand this into all the districts. And already Tirunelveli, Tirunelveli is into it. Tirunelveli, training. We have started already the activity before the funds have flown. Gerald, sir.
So just for understanding, I just wanted to ask one doubt to Dr. Grace. This 30-day mortality, because normally we want to reduce the infant mortality rate. So that means that the services are good and that we have prevented infant deaths. Same thing applies to the other deaths also. But whereas in 30-day mortality, we'll try to look at anybody dying within 30 days of a specific disease or a thing. Now, this how is it actually looked at? It's because they might have been diagnosed in a hospital, but they may die at home, or some will die in a hospital. How we grade the services and death based on this criteria?
Mortality which you presented, and also for clinical care quality, you have mentioned as 30-day mortality. Probably is wanting some clarity in that test.
Okay. So from what I've gathered from the UK, from the UK, cutoff that they have determined is the 30 days. Now, once a patient goes home, there should be mechanisms for follow-up to ensure that the patient is not deteriorating. Now, and that's within the protocols, the standard protocols of the country. However, where patients have been either discharged in the hospital or situation is, and the patient dies before the 30-day mark, then the hospital is penalized because to quality of care within the hospital. And then if it is beyond the 30-day mark, then that is okay. And so what happens is that for some, depending on how the scheme, in some cases the hospital loses funding, or if they had gotten funding prior, that funding returns.
So, thank you. Thanks to all. And thank you, sir. Thank you, ma'am. Thank you, Dr. Manju. Let us close for the day, so at least this session. Thank you, sir. Thank you.
I now request